Good afternoon, dear colleagues. In my talk, we will discuss the relationship between the scleral lens and the ocular surface. Scleral lenses are rigid and gas-permeable ones. The feature of scleral lenses is that they rest exclusively on the sclera and do not touch the limbus and the cornea. Before putting on, the lenses are filled with sterile sodium chloride or hyaluronic acid solution and then are put on the patient's eye surface. Scleral lenses are always well tolerated by patients and always comfortable. There is a tear layer between the lens and the cornea during the entire period of wearing the lens. The thickness of this layer ranges from 150 to 350 microns. The lens does not touch the cornea and does not cause corneal syndrome. In our practice, we use scleral lenses manufactured by the Optics laboratory, located in Moscow. This is the most modern laboratory in Russia, which was developed according to international standards and has an ISO 13485 certificate, which confirms the high quality of the products. More than 4 years ago, we started developing our own scleral lens design. And in 2019, we have already received a registration certificate for a medical device, the scleral lens, and a permission for their use on the territory of Russia. Scleral lenses are rigid, gas-permeable. It would be more correct to arrange this picture not horizontally but vertically, like here. The question arises how the lens is attached to the surface of the eye. There is an atmospheric pressure pressing on the lens from the outside. There is a sublens fluid layer between the lens and the cornea, producing the surface tension force. This is how the lens adheres to the eye surface. The eyelid's pressure also acts when blinking. With each blink, the lens is brought closer to the corneal surface and the loss of sublens fluid layer occurs. And we ask ourselves a question: how fast is the loss of the sublens fluid layer? The distance between the rear surface of the lens and the front surface of the cornea in the center is called the central clearance. We conducted a study in which we found out how the central clearance decreases over time. The data from the study will be published shortly. Let's discuss the results now. After wearing scleral lens for an hour, the thickness of the sublens fluid layer is reduced by about 40 microns. This is about 10% of the thickness. And after 4 hours of wearing, it is already minus 85 microns. This is already 26%. And the question arises, what happened to the central clearance after 6, 8, 10, 12 or 14 hours of continuous lens wear? Of course, the longer the patient wears the scleral lens, the thinner the sublens fluid layer becomes. And what's happening? The loss of fluid occurs. There is a negative pressure arising between the lens and the cornea. We can confirm this by demonstrating conjunctival prolapse. What happens to the intraocular pressure if the lens sticks to the eye, actually? We found only few studies on the intraocular pressure, the most interesting of which, in our opinion, is the study of our colleagues from Pacific University in USA, which showed the following. The experiment involved 14 people who were wearing scleral lenses and included the transpalpebral intraocular pressure measurement before putting on scleral lenses and immediately after that. And it was found that the IOP increases by 5.5 mm of mercury immediately after putting on the lens. And after 8 hours of wearing, intraocular pressure increases by 7 millimeters of mercury. Immediately after lens removal, the intraocular pressure returned to its original values. What can we say about the forces that influence the position of the scleral lens? The lens is held to the surface by surface tension. From the outside, the atmospheric pressure presses the lens, and also the pressure of the eyelids when blinking. Negative pressure occurs under the lens. The longer the patient wears the lens, the greater is this pressure. The intraocular pressure rises by 5 to 7 millimeters of mercury. How thick should the cornea be to withstand all the forces that act on it? Understanding of all these circumstances led us to develop recommendations for the timing of fitting after various interventions on the anterior segment of the eye. We recommend fitting scleral lenses at least 3 months after cross-linking, for example. Of course, epithelialization occurs in 3 to 4 days, but this is not a matter of epithelialization. The first 3 months is the period when the innervation of the epithelium is restored, and this is the period when the most intense processes occur in corneal stroma, and refraction also changes during this period. Of course, refraction changes longer, for up to 1 year. According to reports of some authors, up to 5 years. So, 3 months is the period when these processes take place most rapidly in the stroma and epithelium, and we try to fit only after this period. Fitting scleral lenses after keratoplasty. Let's distinguish between lamellar and penetrating keratoplasty. It's an advantage for us to fit patients with penetrating keratoplasty, as the corneal transplant has a uniform density and uniform refraction. We often achieve good results and high visual functions up to 20/20 and above. In patients with lamellar keratoplasty, we do not know whether it will be possible to achieve a high refractive result or not. It all depends on the difference between the cornea of the donor and the recipient and how much they fit together. You always have to measure. In any case, we fit only 6 months after removing the sutures. We all know perfectly well that only after the sutures are removed, the transplant assumes its position, in which it will be for many years after the operation. And we can fit scleral lenses only after the refraction stabilizes.
И этот процесс тоже такого восстановления, заживления протекает достаточно долго. И после стабилизации полностью рефракции мы можем подобрать склеральные линзы.
Intraocular lenses implantation. Lens capsule fibrosis occurs during the period of 3 months. We do not talk now about the scleral lenses fitting for age-related IOL implantation after typical cataract extraction. Here we're talking about combined surgery in cases when there are scars on the corneal surface, after injuries or after transplantations. It is a highly regular cornea. Cases when it was not possible to calculate the correct refraction of the intraocular lens and when there is wrong cylinder axis position in the result. Then, after 3 months, you may fit scleral lenses and achieve a high result. Now, corneal segments implantation. Minimum 2 months to wait. usually 3 to 4 months after segment implantation. There are two main rules actually. First, wait at least 2 months after surgery, and second, stable keratometry data and stable visual function. Tissues around the segment should be absolutely intact. It doesn't matter where the segment is implanted. The segment should be in the cornea as long as needed. It should not be removed necessarily, and there is no need for an extra surgery procedure. We just fit scleral lenses in such cases after 2 months.
Столько, сколько это возможно и нужно пациенту. Лишний раз на операционный стол идти не нужно. Значит, сегменты мы видим разные. Это кольца, полукольца, единичные
We see
сегменты,
different
разных
segments,
производителей
rings,
и так далее.
half
Это не
rings,
имеет
and single segments from
значения.
different
А вот
manufacturers.
что важно,
It does
и на
not
что
matter
надо
at all.
обратить внимание, это на расположение
But
сегмента.
here's what's important.
Конечно, мы должны
Attention should be
оценить
paid to the
соотношение
segment's
между краем сегмента
localization.
и
We need to assess the
прилежащими тканями.
relationship
И как вы
between the
видите
edge of the
на
segment
рисунках
and the edges and
слева,
tissues.
расстояние
As you
от
can
края
see in the
сегмента
pictures on the
до
left, the
эндотелия
distance
составляет
from the edge of the
совсем
segment to
много,
the
42
endothelium
микрона.
is 42
В таком
microns.
случае мы
In
не
this case, we
можем
cannot
гарантировать
guarantee a
безопасность
safe
работы
fitting of
спиральных
scleral
линз,
lenses,
потому что
since with the
при всех
influence
тех
of all
силах,
forces,
которые влияют
protrusion of these
на
segments may be
организм при ношении
provoked,
линзы,
which we do
вполне
not want to
возможно
happen.
такое
A
инициирование
consultation with a surgeon is necessary
естественной
in this
протрузии
case,
этих
and
сегментов,
then a thorough follow-up.
что не нужно.
In the
Поэтому
other
нужно
examples,
проконсультироваться
the
с
segments
хирургом в этом
are located
случае
far
и,
enough
возможно,
from the
просто
interior and
наблюдать
posterior
пациента и
surfaces
отказаться от
of the
покупки
cornea,
спиральных линз.
and fitting
В остальных
scleral
примерах
lenses is absolutely
сегменты
safe.
лежат достаточно далеко от как передней, так и задней поверхности роговицы, и подбор скалеральных линз абсолютно безопасен.
Now let's go back to the thickness. What should be the minimal corneal thickness? At least 200 microns in order to withstand all the forces that affect the cornea. But what are these 200 microns? Where are we going to measure it? In the center, or is it the minimal thickness? Will we take into account the total minimal thickness or just the thickness of the stroma? We will now discuss these points. What is considered to be the thickness of the cornea, the minimal thickness of the cornea? Take a look at this picture, please. This is OCT of a patient who came to our clinic with a minimal corneal thickness of 560 microns, a central thickness of 590 microns. But where is the possible pitfall here? Usually, all OCT and also SHAMFLU cameras measure the cornea thickness in the central area of 6 to 8 millimeters, as in this case. But take a look at these pictures. This is a patient with Terrien dystrophy, and of course her maximum thinning is not in the center, but near the limbus. And the thinnest spot we found was 81 microns. Despite the fact that OCT shows us a minimal thickness of 560 microns, we have first to examine the patient with a slit lamp to perform biomicroscopy and find the thinnest spot, and only then we perform OCT. Moreover, we manually position a linear scan in order to find the thinnest zone on the cornea. You may find the same effect in patients with inferior conus, extreme inferior conus, or pellucidal corneal degeneration. when the central part of the cornea is relatively thick. In this case, it is 389 microns. At the periphery, at the top, in the thinnest place, it is 100 to 150 microns thinner than in the center. So, speaking about the thickness, we should find the thinner spot in the cornea. And the next point to pay attention to is, what is this thickness? Is it the total thickness of the cornea or just the stroma? We all know that the epithelium does not have a bearing function. When we talk about the thickness and the rigidity of the cornea, it is about the stroma that we're talking. But also OCT and Scheimpflug cameras measure the total corneal thickness, that is, from the interior surface of the epithelium to the posterior surface of the endothelium. See what we get. A patient with keratoconus. The minimal corneal thickness is 312 microns, and according to pentacount data, it's 325 microns. With linear scans, note that a large proportion of the corneal thickness is made up of the epithelium. In fact, the stroma is only 89 microns. So what we call the thickness here? Probably it's the stroma. Thus, a total corneal thickness more than 300, in reality it is about 100 microns. And it's time to look for a surgeon here and not to fit lenses. Another example, according to OCT, the corneal thickness is 229 microns. You should check about the thickness, what you have measured. But at the same time, there is not even a proper epithelial plaque here. Part of the epithelial plaque is filled with the patient's tear. We see the measurements of the divides from the surface of the tear film to the endothelium, and the stroma is only 85 microns thick. The question is, can we in this case achieve high visual functions? Of course we can. The thickness of the cornea does not affect the optical properties of the cornea or the lens in any way. Especially the thinning occurs in the paracentral or peripheral area. When fitting scleral lenses, there will always be a good result. But yet safety is the question, so you should choose the patient properly. Выдержит ли роговица все те силы, которые на нее влияют. Therefore, when fitting, we assess the thickness of the cornea in the thinnest area. And first of all, we look at the thickness of the stroma. And I think it's being the most important. But it's not just the thickness of the cornea that plays a big role. Attention also should be paid to the tissue structure. A classic example here, which I use in almost all my lectures. Here, everything is okay with the thickness. Good stroma, more than 200 microns. But pay attention to the structure. In this case, we rejected the scleral lens's use, because there is no elasticity, and I was afraid of the possible conus development. The patient was unhappy and even grumbled, and I gave him my card and my personal mobile phone so that the patient could contact in case of any problems, of any sudden visual loss, and so on. Я его сопроводила своей визиткой и личным мобильным телефоном для случая, если что-то с ним случится, вдруг резко потеряет зрение, чтобы он мог со мной связаться и проконсультироваться. And actually, it happened a week later, or about in 10
10-дневные
days,
раны, резкий
the patient called
отек всей
and
стромой,
came
ну и,
with
конечно,
a
это остеохондроз.
rupture of the
Поэтому это уже
descemet
без
membrane,
значения
and you see
склеральной
the
линзы.
edema of the entire
Поэтому,
stroma of the
такие моменты
cornea.
бывают, об этом нужно
Of
помнить и
course,
обращать
this is an
внимание на
acute
такие
conus.
детали. Еще о чем хотелось бы
It
поговорить, это
happened
о
without
рубцах
wearing
после
scleral
кератотомии.
lenses.
Все мы
Such
прекрасно знаем,
situation
что
happens
рубцы
sometimes, so you need to
кератотомические
be
бывают
very attentive
радиальные
to your
и
patients.
тангенциальные.
And I would like to
И
talk
опять
about the
же, когда мы
keratotomy
подбираем линзы
scars.
склеральные таким
Keratomic
пациентам, мы должны
scars may be
помнить,
radial
как
and tangential.
эти рубцы будут себя
When
вести,
choosing
какие
scleral
силы
lenses, you
будут на
need to
них
take into
влиять и
account
что
how the
может
scars
быть
will
в результате
behave
нашей
when wearing
операции.
lenses, what
Все
forces will
силы,
affect them, and what may be the result of our
поверхностное
actions.
натяжение
All
под
forces,
склеральной
surface
линзой
tension,
действуют
under
от
the scleral
периферии
lens
к
tend
центру.
from the
Поэтому все,
periphery
что мы
to the
видим,
center.
и изменение тканей, мы
Therefore,
тоже
tissue
направлены
changes are
от
directed from the
периферии к
periphery
центру.
towards to the
Сейчас
center
я
too.
объясню, о чем идет речь.
I will
И поэтому,
explain
когда
it
мы говорим
now.
о радиальных рубцах, то мы можем быть спокойны. Ничего с ними не происходит. Даже в тех случаях, когда у них есть
Therefore,
расхождение края или
nothing happens with
васкуляризация,
radial
никаких проблем
scars.
не будет.
Even
А
in
вот
cases
с
where there is
тангенциальными
edge
рубцами
divergence
ситуация
or edge
несколько иная.
neovascularization, nothing
Конечно,
happens.
опять же, по своей
But
плотности
with
рубцы могут
tangential
быть
scars,
разными.
the
Как вы видите,
situation
во всех
is
этих трех
different.
случаях нет рубцовой ткани. Место кератотомии
Scars
заполнено
may
эпителиальной
differ in their
пробкой, и по
density.
сути
In
вся
all three
кровеносность
cases,
этой
there is
конструкции
no
держится
scar
только
tissue
на
you may see. The keratotomy
симметрийной ткани,
lesion
которая
is
как гармошка,
filled
она
with an
наверняка
epithelial
много
plug.
раз
The entire cornea rests
становилась
on
шире, уже,
descemet's
держала на себе
membrane,
роговицу при
which has
каких-то
become
перепадах давления, и
narrow and
поэтому таким
wider
образом
several times due
деформировалась.
to
Конечно, в
corneal
таких
movements.
ситуациях
And
подбор скlerальных
therefore,
линз
in this
приведет
case, the
только
scleral
к
lenses use will
раскрытию
lead to
рубцов.
the rupture of the
Поэтому так
scars,
делать
very
нельзя.
probably.
И это
We
раскрытие
see this
рубцов
in some
мы
patients,
участи
even without
наблюдаем.
scleral lenses wear.
И у некоторых
As you can
пациентов
see
даже
in the pictures,
без
some of the
подбора
scars are
склеральных линз.
filled with an
Как вот
epithelial
на таких
plaque, and
снимках
the outer part
часть
of the
рубцов
scars
заполнена
is
эпителиальной
slightly
пробкой,
open.
и наружная часть
Because
рубцов
the cornea
немного
breathes
приоткрыта, то есть
and it
кровенеция
moves,
дышит,
and in
она
such
движется.
cases it is
Конечно, в таких случаях
impossible to
для
put on
деятельности
the
склеральной
scleral
линзы
lens on
такую
such a
роговицу
cornea,
не
and
представляется
as
возможным, потому
this will
что это
lead
приведет
to
к
rupture of the
разрыву
cornea in the
роговицы в
place of
этом
the
месте.
scar.
Это я могу точно
I will
утверждать, потому
show
что я
you
всегда
one
показываю
example
клинический
from
пример.
my
Это
practice.
пример из моей жизни, моей
This is a
практики. Это моя
patient with
пациентка,
congenital
первая и
scars
единственная с
and an
тангенциальными
epithelial
рубцами,
plaque
с
in it.
эпителиальной пробкой вместо рубцовой
This
ткани,
is my one
которая
and only
подобрала
case of
склеральные линзы.
fitting
Острота
scleral lens
зрения,
in
ну,
such
естественно,
situation.
была 1,2.
Visual
То есть
acuity
остротой
was
зрения никаких проблем.
1.2.
И через час ношения линзы,
After an
когда была
hour
на
of
подборе,
wearing
ничего
the
с ней не
lenses,
происходило, рубцы были
everything
спокойны.
was okay.
Когда мы
So
уже линзы
while fitting
надевали,
the
я
lens, visual
попросила
acuity was
пациентку через
excellent.
4 часа ношения
So we
линзы,
started
мы
to
обнаружили
prescribe
полную
lenses,
картину.
and when
С
the lenses
радиальными
were
рубцами
dispensed
ничего не
after 4
происходило,
hours, I
а
asked her
тангенциальные
to
рубцы,
come again.
видели,
After 4 hours
видите,
of
они
wearing the lens, you
потихонечку
see that
раскрываются.
tangential scars
Это,
began
конечно,
to
очень
open. You can
страшно.
see it on the slide. The lens
Естественно,
was
мы там
carefully removed. Surgical room
связались с
was ready,
хирургией, очень
but
аккуратно
hopefulли
сняли, что
the
называется, на
scars gradually
пробооперационную эту
closed
линзу.
in
Но,
about
к
half an
счастью,
hour.
все абсолютно
And on the
закончилось
right
благополучно. Не
part of the
понадобилось
slide, you may
никаких
see a photo
вмешательств. И посмотрите, как эта
1
живая
hour
роговица
after
повела
installation
себя в
of
ближайшие
coronary gel.
полчаса. Как вы
And you
видите,
see that
тут же после снятия
hopefully
линзы
everything is okay.
сама
The
поверхность этой
epithelial plaque
линзы
has already
стабилизировалась.
recovered completely,
Этот
and
шов,
we know
края
after that case we no
адаптировались
longer fit
практически.
scleral
Ну,
lenses
а
in
справа это
patients with
снимок этого же
tangential
пациента, но
scars
уже
and epithelial
через
plaques.
час
Although
после
the refractive
закапывания
effect is
картогеля
excellent in
уже
such
и
cases,
закрылась
But
практически
again,
полностью
it is the
эпителиальная
question
пробка.
of safety.
Поэтому, конечно, мы больше никогда не подбирали пациентам с тангенциальными рубцами, эпителиальными пробками склеральные линзы, несмотря на то, что, как я уже сказала, рефракционный эффект был прекрасный, и пациентка видела более единицы. Ну, тут тоже есть такой момент. Что мы
What
еще
else
обнаруживаем
have we
в рубцах?
found in the
Как вы видите,
scars?
в данном
As you
случае
can
тут
see here,
даже
there
полость
is
в
even the
эпителиальной
cavity
пробке
in the epithelial
в
plaque in the
рубце
scar,
и отчасти
and partial
произошла
Bowman
отслойка
membrane
ободовой мембраны
detachment occurred
из-за
here.
постоянной травматизации
Please be
и
careful and pay
выхода
attention to such
кератогенических
things.
рубцов.
Scars
Поэтому,
may
пожалуйста,
include
будьте
both the
внимательны
plaque and
и обращайте на
fibrosis,
такие вещи
which is also not very
внимание.
good and can
Что
lead
еще
to
можно
negative
обнаружить и на что надо
consequences?
обратить внимание?
We always need an
Конечно, на
individual
состоятельность, они
approach
могут
to
быть или
any
с пробкой,
patient.
рубцы я имею в виду, или с фиброзом, что тоже не очень хорошо и
Because
может
scars may
привести
be
к
different
негативным
with different
последствиям.
amount of
Оценивайте
fibrosis.
ситуацию индивидуально в каждом случае для каждого пациента. И еще
And
несколько слов
I would
хотела
like to say
сказать
a few
об
words about dystrophies.
дистрофиях.
While
Конечно, не
fitting
больно
scleral
становишься
lenses,
экспертом
one
по дистрофиям
involuntarily
роговицах
becomes an
в
expert
склеральных линз.
in corneal
Очень
dystrophies.
часто
Very
все
often,
патологии,
the description of
с
such
которыми мы
pathologies in
сталкиваемся в
textbooks
учебниках,
begin
начинаются
with
с
the
фразы
phrase, "This is
«редко
a rare
встречающееся
genetically
генетически
determined disease."
детерминированное заболевание.
But
Но мы
we are
уже
already
привыкли
used to it.
к
It's
этому. Это у
not so
нас
rare
такая
in
практика
our daily
ежедневная. И
practice.
для всех, кто только
For
начинает
those who are
заниматься
just starting to
склеральными
deal with
линзами,
scleral
очень
lenses,
рекомендую
I highly recommend
приобрести
purchasing
литературу,
literature,
атласы на эту тему,
atlases on
потому
the
что
topic,
таких
because there are
пациентов
many
много.
of such
Перед
patients.
вами пациент
Here's an
с
example of a
большой
patient with
дистрофией
lattice
после
dystrophy
сквозной
after
кератопластики
penetrating
по этому
keratoplasty.
поводу и
As
с
you can see
подбором
on the central part above the
склеральной
graft,
линзы.
everything is fine.
Как вы видите,
Visual
центральной
acuity is, in
части
this
на
case is also
трансплантантном
20/20.
абсолютно все
And
благополучно.
after an
Остаток
hour
зрения в
wearing the
этом
lens,
случае
everything
также
was fine too.
была единица.
But
И
after
через
4
час
hours, as
ношения
you can
линзы
see
тоже
in the
все было
picture,
нормально. Но
a
через 4
pronounced
часа,
epitheliosis
как вы
occurred.
видите на снимке,
It looks like a rim,
выраженный
a ball of
эпителиошизис,
perlimbal
он
area
выглядит
around
как
a healthy
такой
graft.
ободок бул
It looks, of
в
course,
перилимбальной
creepy.
области
At
вокруг
the same
здорового
time,
трансплантата, здоровой
realizing
ткани
that such a
трансплантата.
situation could
Выглядит
develop,
это,
we reduced
конечно,
the
жутко.
clearance as we could,
Причем,
as you can
понимая, что
see, but
может
it didn't
возникнуть такая
help. So
ситуация в
technically
этом
we
месте,
tried to do our
мы,
best,
насколько могли,
but still
уменьшили
complications may
клиренс,
develop.
как вы
The
видите на снимках,
question
то
is
есть
in the
сделали
consistency
конструктивно
of the
все возможное,
Bowman's
но это не
membrane.
помогло.
This
Тут
patient
вопрос
was
состоятельности
rejected to
бовной
use
мембраны.
scleral
И,
lenses, of
конечно, этому
course.
пациенту было отказано в ношении склеральной линзы. Поэтому у пациентов с
Therefore,
несостоятельностью
in
бовной
patients
мембраны
with a Bowman's
это
membrane failure,
неважно, каких дистрофий,
independently
здесь
of the
речь идет
dystrophy
просто о
type, it may
нейротической
happen in
дистрофии
any
и
dystrophy,
дистрофии
fitting a
Когана.
scleral
В
lens
процессе
will
своего
increase visual
развития
acuity,
любой подбор
but
склеральной
and
линзы
also
приведет
epithelium
к действительно
detachment will
значительному улучшению
increase
остатка
as well,
зрения, ну а также к
which we
отслойке
do not want, of
эпителия.
course.
Хотела сказать на тему дистрофии Когана.
Here's a
Очень
case
часто
of
встречающаяся
Cogan's
история.
dystrophy. This is a common story in our
Скажу
practice.
так,
You
в
should
остром
not
периоде,
fit
конечно,
lenses
подбирать
while
нельзя. Ну
recurrence.
и, в принципе,
The
сама
lens
линза может
itself can
спровоцировать
trigger an
вот такой
exacerbation of the
период.
process.
Но после
But
PTK и
after
в кафе, то,
PTK
что
or
пациенту
PRK, after some
предложено
laser
выполнить
surgery,
после
when a
лазерного
membrane
вмешательства,
has
когда уже
formed on the fibrosis,
сформировалась
you may fit the lens.
мембрана
Nothing
именно
happens to the
на
epithelium.
фиброзе после вмешательства,
Even 5 years
подбирать
after,
склеральные линзы можно.
you may use
Производство эпителия
scleral
уже
lenses
происходит.
in
Есть пациенты,
such
которым
cases
уже
with
более
no
5 лет с
doubt.
подобранными линзами с диагнозом дистрофия Когана после PTK с высокими зрительными функциями, с ними все абсолютно
And visual
благополучно.
functions will be
Поэтому,
perfect.
пожалуйста, вы тоже можете.
This is a case of Reis-Buckler's dystrophy.
Что касается дистрофии
We only
Рейса
have 3 such
Бюклерса, у
patients.
нас буквально
We
3
fit lenses
пациента
for
таких.
them only in the cold
И,
season.
конечно, мы им подбираем
Everything is
только в
absolutely
холодный
safe.
период.
lenses have not only a refractive function, but there are always a fluid layer inside the lens. So for such patients, we do not prescribe sodium chloride, but use hyaluronic acid. The surface of the eye is constantly moistened, and the patient feels relief. What solution to use? Typically, we use sodium chloride 0.9%. We use it in sterile baths, 5 and 10 milliliters of volume. We prescribe hyaluronic acid in case for dystrophies, epitheliopathies, cases after corneal transplants, and for scars. We use 0.1 to 0.21 concentration, not higher, because it may produce gas bubbles and decrease vision and so on. We do not want such problems, but in some cases we combine sodium chloride and hyaluronic acid, so mix them.
В некоторых случаях мы комбинируем в натрий-хлор, просим пациента капать несколько капель гиалуроновой кислоты. Такие варианты тоже возможны.
Now, about the contraindications. Allergic conjunctivitis and glaucoma are absolute contraindications, by sure. We do not know how the lens will affect the aqueous fluid outflow pathways. The landing zone begins approximately 0.5 to 0.1 millimeters from the limbus. This is a pars plana projection as well as all outflow pathways projection. So also mind the increase in the intraocular pressure. Over the entire follow-up period, and this is already more than 5 years by now, we have not seen any pathological changes in the optic nerve head to develop in any one of the patients. So for patients with glaucoma, one should avoid scleral lenses. A refusal to fit scleral lenses is justified, since outflow pathways may be affected. Although, with a properly selected lens with a normal landing zone, this should not be the case. For the same reason, there should be a rejection to patients with eye neoplasms. We often see pigmented nevi in perilimbal area, where the lens landing zone may produce traumatic effect with each movement, and nerves may grow, and even worse, that all those effects that we do not want. В лучшем случае к увеличению невуса, но о худшем думать мы не будем. Поэтому новообразование, разумеется, также входит в противопоказания. And now a few words about general contraindications: diabetes, pregnancy, children under the age of 10 years old, systemic diseases in which the use of scleral lenses can cause or aggravate eye pathology, or the lack of conditions to safely use the lenses, mental disorders in which the patient is unable to properly use contact lenses and it is impossible to comply with the recommendations for safely use. Thank you for your attention.